They were created in 1977 by an act of Congress. And just so you know, it takes an act of Congress to change anything having to do with rural health clinics, and they haven't been changed for a long time. They're trying. But essentially, rural health clinics were created very specifically with the idea in mind that it's all about geographic access. They have to be located in a rural area as designated by the census, and they have to be in a medically underserved area, health professional underserved area, or a primary care shortage area, and they have to basically focus on primary care. Their closest sibling would probably be the FQHC, but they are different in terms of how they're reimbursed, how they come up with what their going rate is for the cost of the care in there. And specifically, rural health clinics were built on the backs of PAs and nurse practitioners, which were kind of a new concept back then. They didn't say, hey, we want you to try and use these providers. They said, you gotta use these providers. You have to have at least 50% of your visits done by these providers. You can have a rural health clinic with just a nurse practitioner. You cannot have a rural health clinic with just a physician, just FYI. So why reimbursement is determined basically by legislation and CMS. And usually, in most cases, the only kind of visit that gets billed in a rural health clinic is a face-to-face visit with an approved provider. So those are the NPs, the PAs, the physicians, and also licensed clinical social workers count, certified nurse midwives. There are a couple, I think, people with a doctorate in psychology count. And this reimbursement is at an all-inclusive rate, and the reason that you're going to be hearing and seeing more rural health clinics in general is health systems can actually, with this all-inclusive rate, they can embed a lot of their overall expenses into the rural health clinic in terms of their coders and administrative work. And so I was just in Albuquerque last week at the National Rural Health Association conference, and what we found is, or what I found while I was there, is that rural health clinics are growing exponentially. The last count was over 5,000 rural health clinics, and that's a lot more than there were just a few years ago. These things are very much growing, and you're going to be seeing more and more rural health clinics, and you may have to figure out how to work with them. And aside from this all-inclusive rate, which is cost-based, so basically what it costs to run that clinic for a year is how they generate a report on how much they can get reimbursed for these visits. And the visits, it's made to be very favorable for these areas because they don't always have high volumes of visits, so they have to keep these places alive. But that said, all of the reimbursement is based on provider visits, and so nurses do not get reimbursed for their care. The nurses that we had working, they would do the annual wellness visit, the provider would come in, bill for the visit, do the hospital follow-up, and I know that's the case in most places, but it's very specifically the case in rural health clinics. There are no nursing charges in rural health clinics, really. And so we're seeing rural health clinics expand, and we're seeing opportunities to expand services, and specifically, I was going to talk more about some of the specialty outreach. So what do we know about rural? Rural, they're poorer, they're older, more chronic illness, more obesity, more smoking, and so we have all of these barriers that we know exist in rural. Page County specifically, we fare very poorly in Page County in terms of our health outcomes. We're 79th out of 133, so we're kind of in the middle, but we fare even more poorly in terms of our health factors, the things that kind of strengthen our health system, the resources we have available to our people. 35% of our people who live in Page County per health rankings are obese, 23% smoke, 32% consider themselves physically inactive. We have a lot of barriers. And so we have these barriers along with the geographic barriers that rural health clinics are supposed to assist with. We don't have transportation. We do not have any public transportation in our county at all. There's no Uber, there's no Lyft, there are no taxis. If you get a Medicaid taxi, you might be lucky, but they are usually 30 miles outside the area to even get there. So we have zero, it's all family, relying on family, friends. And so we have geography and transportation barriers, and then we have provider access barriers. We have providers who just, they are an hour outside our, where we live, and we live in a little bowl, literally. We're surrounded on all sides by mountains. And so provider access, we have specialists who come into one of our multi-specialty clinics, usually like cardiology will come once a week. OB will come in once every 2 weeks, I think. Pulmonology comes in like once a month. So we have very limited provider access, and when they do come to our multi-specialty clinic, it can be 4 months or longer before somebody can get an appointment with them. So obviously it's a long turnaround. So they wanted something to ease that that congestion that we have with trying to get people to see a provider if they don't have the ability to get outside the region to see a specialty provider. And so the opportunity here is Tella Health, RHC as an originating site. So rural health clinics during the pandemic, we had to wait until Congress let us do telehealth visits with patients who were at home over our telehealth platform, because we needed special, as I said, it takes an act of Congress to make anything happen in a rural health clinic. That's what we had to wait for. So they were at the ready. But one thing that rural health clinics have always been able to do, really, since telehealth became a thing, was we could be an originating site. And I'll talk more about what that means. So first of all, telehealth, what is it? I mean, we have a special interest group in AAACN that certainly focuses on telehealth. Basically, what we consider as telehealth is all the care that goes on that's not directly face-to-face. It's using a variety of technologies and tactics to do health service, but it's not a specific clinical service. It's more an idea, at least per the Center for Connected Health Policy. And then telehealth per AAACN has a very broad definition, which is all about promoting wellness and management of acute illness and self-management of chronic diseases. But ultimately, it focuses on the use of protocols and algorithms to provide this care. And then collaboratively developing a plan of care, including education, which is most certainly what I had in mind in creating this opportunity. So those are the types of telehealth. I won't go into details there, but the definition specifically for telehealth, you have two different sites. You've got your originating site, which is ultimately where the patient is. So if the patient's at home, that's the originating site. If the patient is in the rural health clinic, if the patient is in the hospital, wherever the patient is, that's the originating site. The distance site is where the provider is. So those are very key things, especially with rural health clinics. And the telepresenter is specifically defined here as the health professional who facilitates one of these telehealth visits. And I have very specific ideas in mind for what I think a telepresenter needs to be, and I created a job description for that I'll discuss. But the distance site, as I said, we had to get permission before we could do that from rural health clinics, but the traditional, and that's what we think of with providers all of a sudden going online, all the clinics closed, but the originating site, you can bring patients to a rural health clinic, you can have them have their visit there, and that can be reimbursed. So, as an originating site, it doesn't pay a whole lot, but there is a specific code that allows for that, and the reimbursement is $23.17. And this is something that a nurse can do without a provider, and I saw an opportunity to really expand our registered nursing wings, as it were. And full disclosure, I had seen a presentation from an area hospital where they had an RHC where they had one RN who was doing similar work, and I saw a presentation, and I got really excited about this idea of bringing people into your rural health clinic to see their specialty provider. So I filed that away for future reference. So the telepresenter needs to really ideally be certified, I believe. I've done this certification myself. There's good education out there in terms of what being a telepresenter means. And really, you need to be a good advocate to educate the patient on what's going to be going on, making sure that you get consent, that you are able to be a good facilitator to focus the visit and cue the provider in on any areas of concern, and then basically using that opportunity to educate the patient on plan of care. And there's no doubt in my mind, and you'll hear some of my frustrations in a bit, that an RN has the best scope of practice for being telepresenters in this particular setting.